All right, I think we're going to get started. So thank you everyone for coming. My name is Jonathan Little. I'm an associate professor in the School of Health and Exercise Science at UBC Okanagan. And it's my pleasure to welcome Dr. Eric Westman today from Duke University. Eric is literally a pioneer in the field of low-carb, high-fat, and ketogenic diets. And both from the perspective of a practicing clinician on the front lines, he's also conducted RCTs. He's also literally written a book on this, as well as advocating and really promoting a low-carb, high-fat as a treatment or management option for obesity and type 2 diabetes. Eric's here this week from support from a Michael Smith Foundation grant that we have, a C2 Convene and Collaborate grant, which several of the people near the front of the room were a part of. And it was really Michael Smith supporting us to get clinicians and physicians in the same room as researchers in this area to try to co-develop some research priorities and research studies to help in BC and in Canada recognize this approach and hopefully get it into practice. So we've really learned a lot from Eric over the last couple of days, and I'm sure we're going to learn a lot in the next few minutes. And I also want to acknowledge the Institute for Personalized Therapeutic Nutrition, which Sean McKelvey and Jim Johnson are the co-developers of that institute. We're going to send around a sign-up sheet if you'd like to be part of the Institute's mailing lists. We promise we won't spam you, but it's more information related to therapeutic nutrition and treatment of and prevention of chronic disease. And I'll turn it over to Eric. We're really excited to have you today.
Thank you. It's my pleasure to be here to experience and help out with what I believe is the next step, which is rolling out the information, the science that we have. If someone asks you, do you believe in low-carb diets, you can ask them, do you believe in gravity? It's scientific. It's not a belief, okay? So I hope if that made you feel uncomfortable a little bit, I hope at the end of the hour you won't be so uncomfortable with that. This is a scientifically proved area of metabolism and nutrition. So I hope to bring to you some clinical research, again, to establish that this is science, and then some clinical care. I've been using the keto or low-carb diet in a clinical practice in North Carolina for the last 12 years. And so I'll share the information that I've gleaned over this time with you. A couple disclosures. I am an author on the New Atkins for a New You, but get no royalties from it, sadly. Bad business decision back in the day. We thought that as Steve Finney, Jeff Volek, and I were authors, that it would be better to just be paid once and it would be less conflict, but we still have to put it on our conflict slides. So the book royalties I do get from, but I haven't retired from my day job at Duke. I'm in clinical practice 4 out of 5 days a week still. And then I have equity interest in 2 new companies, again, trying to scale up to get this information available to more people, the diabetes clinics, and then Adapt Your Life as a food manufacturing company that makes truly low-carb products. And I'm not going to talk about any of that today. So low-carb, high-fat, or I saw on a slide recently, low-carb, healthy fat. You can use either one, and diabetes. I have to give you a brief history of the treatment of diabetes. There's a Canadian connection there, the other side, Canada. Effect of dietary carbohydrate on blood glucose. This is just physiology. This is basic stuff. And what's the effect of insulin resistance on blood insulin and glucose? And that's where the obesity medicine information that I've been able to work with over time plays into diabetes. What is it? Low carb, healthy fat, high fat, low carb, LCHF for the treatment of diabetes and LCHF for the treatment of obesity. Because once I convince you this is the best thing for diabetes, you're going to still have some, but what about this? And I hope to dispel all of those over the course of this hour. And I'm going to use this as the rough framework for the talk. So a bit of history of diabetes. In the pre-Western era, lots of different things were used for diabetes, but by the beginning of the 20th century, Allen and Joslin and then Osler picked up the idea that maybe a low-carb diet, maybe having people not eat sugar and starches would be a logical way to keep the blood glucose or blood sugar down. So, in fact, Elliott Proctor Joslin wrote in 1893, dietetic treatment is of first importance. The carbohydrates taken in the food are of no use to the body and must be removed by the kidneys, thereby entailing polydipsia, polyuria, pruritus, and renal disease. Mary H. was put on a stringent diet consisting only of protein and fat. Horrors, right? The beneficial effects were seen at once. Medicine can become strong immediately. She gained 5 or 6 pounds and was advised to eat all the cream, butter, and fatty food possible. Oh, but this is just one guy, long time. Oh, no. Frederick Allen, now we get into the medical literature. Of course, this is 1915. This is 100 years ago. In the treatment of diabetes mellitus, Allen employed fasting. Fasting. Have you heard of that recently? Meaning, it's funny, I have to give people permission not to eat all the time. At least that's what I have to do in North Carolina. Then stepwise reintroduction of macronutrients to find the threshold at which glycosuria develops, so glucose in the urine. They didn't have blood glucose measurements. So this is a relatively crude way to treat diabetes. We can do better now, I think. So the patient was fasted until glycosuria was no longer present. Then carbohydrates in the form of green vegetables were introduced, starting at 10 grams per day, and increased until the glycosuria threshold was reached, meaning you started having the glucose in the urine. The carb intake prior to the appearance of the glycosuria was considered the optimal amount of carbohydrate. Turned out that it was about 40 grams for the whole day to prevent glycosuria. This level was maintained, and then protein was added to the diet. Did you know that eating protein can raise the blood glucose and urine glucose? Yeah. So this is also a factor when you're trying to treat diabetes. The protein matters as well. So they began with 1 to 1.5 grams of protein per day per kilogram to find the glycosuria threshold for the combination of carbohydrate and protein. Finally, fat was added to the diet to provide calories for weight gain, for weight maintenance. Fat was observed to have little effect on glycosuria. For some patients, a weekly fast day was recommended. How did this get all crazy? So 100 years ago, before there were any medications, one of the prevailing textbook of medicine, and we all, as internists, stand up a little straighter, get my shoulders up when we mention Sir William Osler. You can handle the original book that Lady Osler owned in the library over at McGill, and they make you use kit gloves to bring it out. And while this table wasn't in the first edition, it was basically the same approach. And this is a 10-gram carbohydrate diet for the treatment of diabetes and actually obesity, but we're talking about diabetes so far. So just to bring that information into a larger format, so 10 grams of carbs, protein 75 grams, fat 150 grams, alcohol 15 grams. Why doesn't my patients focus on that all the time? You mean I can have alcohol? Yes, actually alcohol can lower the blood glucose. And the very diet that was used 100 years ago is what I use today in my clinical practice for the treatment of diabetes. Still works. How did this all happen, and what is the biology, what's happening in our bodies? Insulin replacement therapy is probably the most important advent, new drug that changed everything. And so before the discovery of insulin, an individual with type 1 diabetes, an individual who can't secrete their own insulin, would become emaciated. So you can't store fat without insulin. So these children would be skinny. very skinny, can't store fat. And they would lose energy in the urine from the glucose. And despite eating a lot, there would be no fat storage. So this was called starvation in the midst of plenty, and because the body would be thin, because the large energy intake could be given. So insulin replacement therapy for insulin deficiency or type 1s saved lives, totally saved lives. Problem is, for type 2 diabetes and obesity, it's not the answer. It's a short-term fix, and here's why. So on the left-hand side, it makes total sense to give type 1 people with type 1 diabetes insulin. The remedy is to give insulin. On the right-hand side, however, with type 2 diabetes and obesity, there's already too much insulin in the blood. Can you imagine the surprise of the researchers who saw people with high blood glucoses and they measured the insulin and it was high? How could this be? If insulin's job is to keep the blood glucose down, well, so they came up with this idea of insulin resistance. Insulin doesn't work as well, and let's just give more insulin. Well, why not consider this other option, which is that there's too much fat storage and it's too much insulin already, so the remedy actually is to reduce the insulin, not give insulin. And so this is the fundamental change in medical practice and then in research that got people off track from what was used 100 years ago, which was totally diet. And the mainstream got onto this. So second half of the 20th century, beginning with the American Diabetes Association, without really any evidence, tracking back the history of this, and it was a couple experts who did a couple really bad studies who then just came out and said, you have to have a high-carb diet if you have diabetes. And then that led into the idea that you have to have medication because you're eating the carbohydrates that raise the blood glucose, and so thus the spiraling. Today, the mainstream guideline for diabetes treatment starts with medication. Really kind of unbelievable when you get this into the pathophysiology of this. Let's just go over some basic physiology. You eat carbs, the blood glucose goes up, and insulin goes up to keep the blood glucose down. Amazing that a study had to be done in 2003 when I first got into this area because people forgot the basic biology. So this Bishop paper was, oh my goodness, a low-carb diet doesn't raise the blood glucose and insulin. Well, are there any physiologists left in academia, actually? It's very interesting. And then it's not just in Europe where that study was done. It's in Australia. It happens in the U.S. It happens among native populations. This was Manny Noakes, who did a paper or did a series of studies in Australia, in Adelaide, and basically in red, the blood glucose and insulin goes up less on a zero-carb diet. That's on the right side, right two panels. The red is a single meal with no carbs. So the glucose doesn't rise, the insulin doesn't rise. Conversely, or in comparison, in the yellow and green lines, the blood glucose and insulin goes up when you eat carbohydrates. And this is 2006. So just recapitulating basic physiology. Now, for people with diabetes, same holds true. But also I want to point out that insulin resistance makes the glucose levels and the insulin levels higher. So this is in black, the control group, meaning their controlled diet with carbohydrates among people put on a metabolic ward. So if there's one paper to read that because they have total control of the diet in this study, this was Gunther Boden, Annals of Internal Medicine, 2005. It's the best evidence that hunger goes down, people match their protein to their weight on an ad lib, low-carb keto diet. And also among people with diabetes, the glucose and insulin stay lower, the bar, the white dots there. Well, of course, that's not enough, right? What happens in real life, real people out there. So we've done a couple summaries, published them in a recent textbook called Ketogenic Diets, which is largely the new animal research that's being done. But I have a summary chapter in there, kind of like this, showing that when you reduce carbohydrates, the A1C over time, and it could be from 3 to 24 months, depending on the particular study. And the study that we did stands out because the way this works is the number here is the comparator group of carbohydrate, and we were one of the only groups that would look at a 20 gram per day total carbs for the day kind of diet for diabetes. And if you look carefully, we had the greatest clinical effects as well. Now, people look back and say, well, that's all well and good. It's kind of small studies and all this. But remember, we're talking about basically reproducing what we know basic physiology to be, that the lower the carbohydrate in the food, the lower the blood glucose is going to be. How could this possibly be true? Well, I've had endocrine professors come up to me after endocrine grand rounds, the lectures we give, say, I never thought of it this way. So if you take, it's in front of the nose, oh, sometimes you don't see the nose on your face. You measure the blood glucose at 5.5. How many, okay, I have to tell you that there are 5 liters of blood in the human body. How much sugar is there in the entire, how much glucose in the entire bloodstream? Multiply, you know, this is like elementary school mathematics now. I think I got that right? There, for you want to check that on your, I usually do it in milligrams per deciliter, but in millimoles. So basically there are 5 grams of sugar, glucose, in the bloodstream at any given moment. That's a quarter of an apple. That's a third of a slice of bread. So if you eat those things, it's going to double the blood sugar if it was all absorbed at once. Now what you can imagine happens is insulin goes up to keep the blood glucose down, and really the phenomenon that we're trying to protect against is the insulin and glucose going up, especially with type 2 diabetes. You want to keep the insulin down. Why not reduce the contribution of sugar and starch? Oh, starches get digested to sugar very efficiently in the stomach. Just ask someone with diabetes to measure their blood sugar after eating a potato or a piece of fruit, and their blood sugar will go way up. But I recently learned that in some places, not everyone has a blood glucose meter like my patients. Everyone has one. They're measuring it. They're coming in, showing it, checking it. So, but that's one way to even show in that given individual how this all works, how small amounts of food can change the blood glucose. Now, you might, the first question is, okay, you show keto diets work for diabetes. It makes sense that blood glucose will be lower, but the body needs carbohydrate, doesn't it? Well, this was the first question I wanted to be answering before I got into any deep research here. I didn't want to hurt anybody. But does the body really need, do you really need to eat carbohydrate? You may be surprised to know that the best resource we have, the Institute of Medicine that's unbiased, says the lower limit of dietary carbohydrate compatible with life is 0. You don't need carbohydrate in the diet, provided there are adequate amounts of protein and fat. A little bit of protein and fat can be converted into glucose. And the minimal amount of exogenous and endogenous carbs is dependent on the brain. I've seen papers where world experts get together and say because the brain uses 100 grams of glucose, you must eat 100 grams of glucose. Remember, there's this thing called gluconeogenesis, that your body can actually make glucose internally without eating it. I mean, how could someone live for a month? How could someone go out on the reality TV show and be put on a deserted island and come back 21 days later and not be dead, right? I mean, so I just smelled a rat with this, huh? So it turns out the best estimate after keto adaptation, so after you go from carb eating and carb burning to not eating carbs and fat burning and ketone burning, the brain starts using ketones, and it's estimated that only about 20 to 30 grams of glucose are required in the brain tissue. And the estimate we have is that the liver and kidneys can make up to 200-300 grams of glucose a day, easily supplying the nervous tissue. So I felt comfortable getting into this research that at least from lowering the carbs, I wasn't going to harm anyone. So now, what does keto mean? What is a low-carb diet? And then I'll show you how we've used it clinically. If you look at the typical Western diet, it's 200 to 300 grams of carbohydrate a day on the upper right-hand side. We defined in a paper 2007 a low-carb diet to be from 50 to 150 grams per day. And then a keto diet is when you get under 50 or 20, depends on the person, of total grams of carbs per day. And then the biologic appearance of ketones somewhere, either blood or breath or urine. And the problem is these are all different molecules, and no one really knows what the right levels are yet. But what's exciting is we're studying it now. We, as the royal we, the world is not afraid of this, and they're studying all of the ketones and the effects of ketosis. So when you go below the keto threshold, however you want to define it, you call it a keto diet or a ketogenic diet. If you just step back and teach people, I teach patients every week in North Carolina, a wide range of socioeconomic status, wide range of educational status. And if people ask me about good and bad carbs, I say, yeah, the bad carbs are the junk foods. So, and this is a common theme of pretty much all the popular diets. They're not recommending Snickers or Mars bars or whatever. And so the good carbs are the low glycemic. They don't raise the blood glucose carbs, the vegetables and leafy greens mainly. And if you go to dietdoctor.com, which is one of the world's resources for information about this on the internet, this is kind of the stylized view from Sweden of what a ketogenic diet could be. Not too bad, huh? And so I try to get away from language like keto or something that someone might think that it's bad or good. I just talk about food and say, here, eat this food. A lot of things will get better. Sorry, I'm a little out of place. Some people don't trust or value those individual studies, and so there are systematic reviews now of the use of low-carb diets for diabetes. And what you see here in this one is that the lower in carbs you go on the x-axis, the greater the change in hemoglobin A1C. So lower the carbohydrate in the food, the general theme across different studies is that you'll get better control of diabetes. The American Diabetes Association, Will Yancey is my colleague at Duke, has kind of at the moment, a schizophrenic view if you read the papers, because some of the guidelines and papers say low carb is fine, others say it's not. And the unifying theme is that my colleague Will Yancey is on the papers that have the data on low carb, and they come through the American Diabetes Association. So he's still trying to work within the system to change those recommendations we saw from the American Diabetes Association. And then other systematic reviews showing carb intake and A1C. Again, some people won't value the information until you have meta-analyses, and for a network meta-analysis, which means the size of the nodes are the total N and the thickness of the lines are the number of studies. There is as much research on low-carb diets for diabetes than there is for vegetarian, Mediterranean, and moderate carb still works well. There were 56 studies in that one. So my colleague Will Yancey at Duke thought, this diet is as good as a diet and a drug for weight loss. I'm going to get into a little bit of the weight loss studies too and application. So he did a randomized trial of using a low-carb diet versus orlistat, which is a fat blocker, and a low-fat diet. This is kind of the standard of care back in the early 2000s for what a doctor would use for the treatment of obesity. And the average weight loss is shown in the solid lines. The low-carb diet worked as well as a drug and a diet. diet and a drug. So the individual lines show each individual patient or subject. So here is someone who had a 32% change in weight over the 48-week period. To do this just by changing the food? Unbelievable. So unbelievable, people don't believe it. Now the research is being done on just a couple of the latest of the last 6 to 12 months. Mice fed a keto diet at middle age live 13% longer. I'd like to see more of these studies, and why not feed the mice from birth a keto diet and see what happens. What about in type 2 diabetes in larger studies? This is the Hallberg paper from a study with 262 people with type 2 diabetes and obesity. The BMI, average BMI is 40. This was done in Indiana. And the take-home point is that just about everyone on insulin had a reduction or elimination of insulin, and there was an average reduction in A1C, 7.6 to 6.3%. Ketones, now that we're measuring them and we know what they do, they're molecules that deliver energy. And when you have a nutritional ketosis diet, you don't get ketoacidosis. It's called nutritional ketosis. And my colleague did arterial blood gases and published in a paper back in 2007 showing there was no acidosis. There was ketosis, but not acidosis. Still a common source of confusion among the mainstream medical folks. The McKenzie paper is from the Hallberg paper, basically showing, or Hallberg study, the ketone levels among people with diabetes. It's not a normal bell-shaped distribution. It's very skewed, and I don't even recommend measuring ketones in my practice, blood, breath, or urine, because many people have success without getting what's defined as ketosis. I think that's a bit of a misguided thing, although it can be useful for some people to measure to keep them on track. And I will sometimes recommend the use of ketones to troubleshoot if someone's not losing weight or the diabetes isn't getting better. But beta-hydroxybutyrate over time, again, in this study with people with diabetes, tends to go down, but on average, there's still a lot of individual variation. A lot of research yet to be done on what happens with the ketones before I'm comfortable knowing what to say clinically. So outpatient low carb. So what about weight loss? Have to just go back a little bit. Talked about diabetes, now obesity by itself. So it's not that low-fat or low-calorie diets don't work. It's just that low-carb diets work better. And so if you have the right metabolism, if you're insulin sensitive, not insulin resistant, actually a low-fat diet can work. Thus, you can have businesses like Weight Watchers or other programs that don't really use low-carb approaches, but it doesn't work for everyone. And if you took people side by side, low-carb works better on average. 2-year studies now. This is the best one with outcomes of carotid intimal thickness. Ivry Shai in Israel. It didn't matter what diet people were on. The carotid intimal thickness got better, meaning reduced, if they followed the diet, if the blood pressure went down, and if they lost weight. So if they basically were adherent to any of these diets, there was an improvement in the carotid intimal thickness. You line them all up, and now there are meta-analyses. This is Bueno. There's also Nordman and all other meta-analyses of low-carb versus low-fat. So there's the first round of a lot of people trying to show that low-carb didn't work. And what they found is that low-carb worked. And so most of these researchers didn't sustain a research program in it because what they wanted to find wasn't found. Or you could argue that there wasn't the funding available yet, and it's still, there are a couple NIH researchers, investigators funded now in the low-carb space. My colleague Will Yancey has been funded through the Veterans Affairs Organization in the U.S. continually for the last 10 years now. Before I leave this one, this sometimes isn't enough. If you want to go to your smartphone and go to the Public Health Collaboration of the UK, phcuk.com.org. Click, click, click. You have these studies side by side, so you can show this to your doctor in 1 minute, or your dietitian, or your colleague, your mother when she comes for the holidays. I mean, it's just amazing that people need to be trained, and the quickest access to this information is through that organization, Public Health Collaboration in the UK. Great figure for talking about, well, what about the cholesterol? You know, it's funny. Did anyone read this book, The Little Prince? Saint-Exupéry. It's existential. Everyone who learns French years ago would read this book. And the Little Prince went to the planet of the alcoholic and said, "Why do you drink?" And the alcoholic said, "To forget." And the Little Prince said, "To forget what?" And the alcoholic said, "That I drink." So if you get into addiction, this is kind of it just doesn't make sense. You're stuck in this vicious cycle, and I feel like that. When I go to the diabetologist and I say, "But you need to use a low-carb diet," they say, "Well, but the LDL goes up." And I don't treat LDL. You have to talk to the cardiologist. I go to the cardiologist, and "Why don't you use LCHF for the diabetes?" And they say, "Well, because we don't treat diabetes. Until the endocrinologists sign off on it, we're not going to use it. The cardiologists won't use it." And I go, "Well, and all cardiologists know is that bananas have potassium in it." And so what's happened is that medical specialists don't understand nutrition. And so they're waiting for the other professional to sign off on it. And so now this paper shows in one figure, again, you have to get the information that it's like, duh, that everything got better. This is the Hallberg paper, except the LDL. Gosh darn it. I mean, if there was just one random thing that couldn't, on average, get better all the time, it had to be the LDL. Because there's been an LDL focus in the cardiology research and clinical world in the U.S. and in Canada as well. When you look at the type of LDL, actually it changes. So if you're just looking at the total LDL, it might go up. In fact, it's a little bit of a probability is that 2/3 of the time it actually gets better. But 1/3 of the time it gets worse. And 1 million people is a lot of calls and emails to me saying, "What about my LDL?" People fly from other parts of the country so that I can tell them, "It's okay, your LDL is up a little bit, and you'll be fine." Because look at everything else that got better. That's kind of that Little Prince sort of just strange world that we're in. That you talk to one expert, they say talk to the other expert, and fortunately there are organizations and other people coming around that I'll get to. So there's no mystery how a low-carb diet works for weight loss. People eat less. It's a calorie-reduced diet, but you don't talk about calories. So that mystified the traditional dietetic world. You don't talk about you must restrict calories. It won't work. No, it does. It's just a different way of going about it, which is going to be a common theme. And it's how I reassure people who come to me. So back in 2006, what we estimated, Dr. Yancey and I figured that, there's enough research now that if this was a drug, it would be FDA approved. So let's start using it in clinical practice. And, goodness knows where the last 10 years went. Time flies when you're having fun. And so I have a clinical practice at Duke using 2 rooms, and it's kind of a minimal intervention. There's a clinical nurse's aide and myself. I'm the cheerleader, the nutrition guy, I'm the medical prescriber, all in one. And payment is within the private or public insurance. I rarely get people who pay out of pocket. They assume, in the States, they assume the insurance will cover everything and don't like to pay out of pocket. And the first-line treatment is basically the low-carb ketogenic diet, in the literature, LCKD, or keto diet. So we've seen 4,000 patients over the last 10 years, with 28,000 clinic visits, which keeps me having a salary. You have to find a way to support someone to do this. Most of us won't do this for free, even though we like to talk about it. I need to get paid for it, and the insurance covers it. So the average age of people in my clinic is about 50.5 years, 74% female, half and half Caucasian, African American. Average BMI is 40.5, 50% private, 50% public insurance. I had a student rotate through who has become the expert in extracting information out of our clinical record, our EHR, and he did a summary that we're working now toward publication that we've, over the last 5 years, because our computer changed to the newer system, we know that we've helped 2,000 people lose 26,000 pounds. So remember, if you believe in low-carb diets, do you believe in gravity? You do that, someone who's really recalcitrant, have a glass of water on their lap, and then, it's interesting how the science is there and yet it's not seen. It's not, and I think a lot of my colleagues in research don't read anyone else's research, which is sad. I always thought it was my obligation to read other people's research. So now I run the clinic of last resort. People come to me, I've done everything. People will even say, I did the keto diet, I did the low-carb diet, I did the Atkins diet. It didn't work. And I'll say, well, you never did it with me, which basically means you learned something now over the years beyond what was known before. So we treat obesity, type 1 and type 2 diabetes, PCOS, a common cause of infertility. Sad thing there is people will go through the traditional fertility treatments and have it not work, and then the OBGYN doctor says, oh, your BMI is 40, why don't you go lose weight? Now that we've tried all of these things and it didn't work. And the cool thing is that within a month, women can become pregnant, where they haven't had a regular period and haven't been able to get pregnant. Fatty liver, yes, it's not the fat in the food that causes fat in the liver, it's the carbohydrates. This is the foie gras analogy. Fatty liver, a delicacy for some, is made by feeding geese, force-feeding geese, corn. Oh, I'm sorry, is foie gras outlawed in this area? I think it is in California. So yeah, fatty liver is from carbs, not fat in the food. This common mistake that doctors don't get trained in nutrition or obesity. You just have to understand that. GERD, heartburn, this is the most potent intervention for heartburn that I know of. It's almost 100% in a week. Heartburn's gone. I don't even mention it because people will come back and, I'm not having heartburn. Yeah, it fixes that too. Because if you say all this up front, people will start not believing you. Classic heart failure patient coming to me, we'll talk about that, post-operative bariatric surgery, weight regain. Yeah, most people regain the weight now over time because no one addressed the food after the surgery. We don't use medications or products, and here's what we do. We use a low-carb ketogenic diet, a keto diet. I know people are in ketosis because they're under 20 total carbs per day. And this is true for just about everyone. It might not be true if you're on insulin or on steroids that are powerful metabolic drugs. But so you can tell people to have eggs and bacon or sugar-free yogurt and berries, a small amount of slices of berries, chicken Caesar salad, fast food burger without the bun, olives, cheese, pepperonis, chicharrones or pork rinds, or chicken skins if you're kosher, steak with blue cheese, broccoli, salmon with cream cheese, water, sugar-free drinks. Yeah, diet soda doesn't raise the blood sugar. And I don't know why the industry doesn't get onto this, You can still make money. Coca-Cola, Pepsi, you can make money. Just don't push sugar, okay? That's an easy fix. People are still making money. I don't know why there has to be this radical public health, no Coca-Colaization and all that. Why not just use the basic biology? And what's kind of brilliant is the system that I use is so simple. It's all on one sheet of paper. And people choose what they want to eat. So I spend no time like dietitians saying, do you like hamburgers? Do you like cheeseburgers? Do you like cheeseburgers with bacon? Of course, I don't want you to have bacon, but this is simple. Let people choose what they like. It's brilliant. And I didn't come up with this system. I inherited it, studied it, basically. So this is the classic toughest patient, just to show how powerful yet how elegant it is, just by changing the food. This is a 73-year-old white male with CHF, congestive heart failure, CKD, chronic kidney disease, diabetes, an ejection fraction of 25% of the heart, which in normal is about 40%. An LVAD is a heart implant, a pump that basically pumps the blood around because the heart can't pump. Now, a keto diet with the modification of, you have to be very careful about the sodium and about the vitamin K and the leafy greens, is very effective. I'm not adding new drugs. I'm not making them go through surgery. It's an elegant way to do it. So over a year, he's lost 44 pounds. His insulin requirement has gone down in half. It doesn't always get better quickly, but it can. And creatinine, the kidney function is improved, and his ejection fraction has gone up such that they're considering removing the heart pump. He was going to get a heart transplant. That was the plan. So I now have a growing number of heart failure patients. The surgeons want to operate, but they're too heavy. So surgeons are great people to team up with, especially orthopedic surgeons. They want to operate. They know they have better outcomes if people weigh less. But I trained as an internist who, I can treat anybody, and so this is what a great way to use a diet change. Now, let me give you a couple other clinical cases. This woman had Roux-en-Y gastric bypass, the prevailing bariatric weight loss surgery, back in 1984. And she's 70 years old when she came to me in 2010. I think she'll come to. But this is, surgeons know, all they know is surgery. So if you go to a surgeon, again, with a failure of surgery, they'll operate on you again. And not necessarily ask you what you're eating or drinking. So they basically said, okay, look, you've had 21% weight loss. It's great. Your lifestyle will be better. This is the new guideline. It's even 10% weight loss. It's great. Now, I wouldn't have a business. I wouldn't have people coming back to me if I only got 10% or 20% weight loss. People want it all, and you can achieve that. So this patient saw me, put her on LCHF, used a little bit of diuretic. She had some edema, and her BMI went down to her high school weight just by changing the food. $4,000 in the clinical costs that we billed to insurance. She basically had no expenditure out of this. Each surgery costs about $20,000 in the US dollars. Interesting, the carb quantity is more important than food quality. I'll teach people that basic fundamental low-carb diet. This man, young man, 25-year-old man, came back just eating at a fast food place. On the dollar menu, he started eating 3 double cheeseburgers, no bun. Started losing 15 pounds a month. And then spring break in my area of the world, people go down to Florida, Daytona Beach, and they drink carbs. And so he didn't lose weight, but he didn't gain weight, and he was actually pretty happy about it. And then he came back and kept basically the fast food, no carb diet, and kept losing weight. So carb quantity is more important than the food quality. Let me go to a note of caution. If you're going to treat people who are on insulin for diabetes, beware. The insulin requirement can go down really fast. So you have to understand between this week and this week, I've cut all the carbohydrates or recommended it. People do it on their own based on a simple sheet. Add up all the insulin for the day, 100 units, and you give instructions that if the blood glucose is over 6, you don't use the insulin at that time. So that's my deprescribing method. Cut it in half on the first day and tell people if the blood glucose isn't over a certain, if it's under a certain level, just don't use insulin. What will happen is people will drop insulin doses. If they took 2 a day, they might only take 1 insulin dose that day. That's a simple method of deprescribing, knowing that if the glucose level is this low, they're not going to take insulin. And when they come back to the appointment, you see how many times they didn't take the insulin and cut down by a third or a half depending on the level at the time. So you don't have to have that daily monitoring, but I wish I did. So there are systems now coming into place where you can follow the glucoses over time. People are putting continuous glucose monitors on and watching, and so the safety of doing this, I think, is really important, and yet it can be easily made safe. So this person, before I saw them back at a month, was already off the insulin. And the weight's down there, so the weight at the beginning is 427 pounds. This person was off 80 units in 1 week. Remember, we cut the carbs between week 0 and week 1. Was also on Actos and Metformin. Yeah, these are little things. You just stop them. Insulin, glimepiride, metformin, and off 60 units of insulin in 2 weeks. Didn't really have much weight loss. So this is the diet. Wait, does the diet affect the blood glucose? Yes, 100 years ago we knew that eating food. So changing the food is really powerful, and it's nothing new. It's just kind of amazing how doctors will look at this and go, "Wow, that's amazing." No, it's simple physiology. So 100 units of insulin, cut it in 50% on the first day. Let people know that if the blood glucose is under a certain level, you don't use insulin at that time. This person's off 100 units of insulin in 3 weeks. And I'm getting down to the weeds of how much is the administration of it, and there's a lot of arts to this. If someone's on about half as much of short-acting as long-acting, I'll cut the short-acting under the idea that the food isn't increasing you don't have to cover the food anymore with short-acting insulin. It's easy to just stop the Humalog, and some doctors will say, no, you need to go on this special insulin or this special insulin, and that's too much work for me. I'll work within whatever framework of insulin that person has. If it's Lispro, Humalog, all that, I don't care. Or Tresiba, nice names to make you feel good about taking it. I don't feel good about prescribing medicine. This is another emotional thing that we're getting into this week, the last few days. Doctors feel good about prescribing a drug. I feel good about taking it away. And patients feel good about not taking drugs anymore. So main point here, it doesn't matter how long you've had insulin. You could have had it for 10 years, 20 years. Yeah, there's a lot of, gosh, what would have happened 10 years ago if this person had done it? But I can't go back. Just got to move forward from here. This person was injecting 36 units of insulin 3 times a day and 65 of long-acting, gone in a week. Now, if you didn't reduce the insulin or tell them how to do this and they cut the carbs, they may have a low blood sugar reaction. They're driving, like what happened to me at my clinic last week. This woman's driving by 5 miles an hour, 10 kilometers per hour, and she's looking out the window saying, my blood sugar's low, I don't know where I am. So, fortunately, we rescued her with a low-carb bar that's not truly low-carb. I rescued her by giving her this thing to eat. She didn't really know where she was, and she pulled out of this hypo. But so giving insulin to someone who has type 2 diabetes is not the answer. Let me rephrase that. It's not the only answer. So this is just another way to go about it. This person had insulin for 25 years, off 160 units in a month. And, at our obesity medicine meetings, we argue about, well, we should stop this one or this insulin or the short. I don't know the right answer. Just lower it. I think there's so much insulin resistance still going on with this person with a BMI or a weight of 270 that it doesn't really matter. Some people ask, well, you just showed blood glucoses. What about the A1Cs? Remember, A1C, hemoglobin A1C, is just a reflection of the blood glucose over a 3-month period. But it actually can change in the first month. But here, the A1C went from 10.8 to 7.3% in just the 3 months. So you're almost resolving the diabetes without medication just by changing the food. Amazing. 250. Now we're getting to industrial strength insulin here. 500 units a day. You can imagine the volume. But What pharma has done is they've lowered the volume. Now you can get U500. Oh, no worry, doc. Just use this other one. You don't have to inject so many mLs, so cc's, and your patient will be fine. No. Sorry. That's one way to go about it. Why not consider this way, which is to cut the carbs. And while this man, he and his wife come to me, and yes, there's a definite spillover effect. I think it's about 30% of spouses and families get better when you just help one individual in the clinic. He feels so much better. He's paying less money for his insulin. He's in this little, we call it the donut hole, where the insurance doesn't cover it, and he pays for it out of pocket. He's happy as a clam, even though he's still on insulin. And you have to remember, his weight is still 264 pounds. His ideal weight is probably 150. So still some insulin resistance going on, but it's much better. Just another dramatization of it, how someone might still be on insulin after 6 months because of the underlying insulin resistance from the excessive weight or excessive adipose tissue, fat mass we call it. Insulin pumps, no worries, just make sure you cut the basal down, and then they won't be bolusing. You would bolus before a meal because the meals don't affect the blood glucose anymore. People will just automatically use less. Big study, Facebook, the world's changing in strange ways. We have a Facebook group of type 1, people with type 1 diabetes all doing keto. And one of our fellows did a survey of these patients, or people, and it was so good that a Harvard professor picked up on it and redid it with validation of the self-monitoring with the doctors, and this was published in the journal Pediatrics. The type 1 Facebook group is called Type 1 Grit, all spelled out, G-R-I-T, because he's the dad of David Dykman, is a University of Michigan fan, football fan. So anyway, world changing by Facebook. Pretty amazing, or by digital interventions. It's a changing place, and it's under the right circumstances, it's fantastic. So type 1 and keto, no worries. I send all of my patients to type 1 grit, and it's like a self-managing Facebook group. Okay, doc, you showed me short term, but what about long term? Well, this is just an example that the weight in red and the A1C in blue, not a coincidence that over this 10-year, 9-year period, there was really no change. And then, oops, there's a diet change, intervention here, and reduction in A1C under 6, which had never been there for, prior 10 years, just by changing the food. This is an internist's dream, or nightmare. As trained as an internist, now an obesity medicine specialist, I use my knowledge of medication to take people off the medication. And I've never practiced better internal medicine than I do now, just by talking about the food. It's really pretty amazing. So this person had diabetes, hypertension, gastroesophageal reflux disease, or heartburn. It was following the diabetes diet, as you saw, lots of carbs, checking the blood sugars 4 times a day with medications and insulin, and now none of that. And the A1C is better, and the weight is almost normal. What about the frontiers? Using fat for fuel is a concept that I was never taught. You may have never been taught. The human body can use fatty acids, triglycerides, or fat for energy. In fact, that's a very dense source of energy. If you were going to send someone to the moon, the space station, feed them fat. It weighs less. See, we've all been taught that we don't want the calories. We don't want it, so we taught low fat, low cal. Well, McArdle disease is a rare disease of skeletal muscle metabolism where you can't store sugar in the muscle. So the traditional thinking was, let's wake these children up in the middle of the night and feed them sugar. Otherwise, their muscles can't work. In fact, their heart will have a problem. So really, up until 2017, This is the classic thinking. You give them sugar, give them sugar. Four people got up in front of a low-carb conference where the people are congregating together in a grassroots kind of thing, and they said, we think our myocardial disease is better. 4 people got up. Stacey Reason in the UK tracked them down and wrote this paper up, and basically after short-term and long-term, they noticed increased activity and exercise tolerance. They actually did the genetic testing to verify disease in 3 of them. And now this fall, there's going to be a ketogenic conference for muscle disease in London, 2008. So it's case studies, anecdotes, rare people getting together, internet support, internet, Facebook. I wasn't taught about this, and I wasn't taught that the muscle could use fat. In fact, the muscle prefers fat. The heart muscle prefers fatty acids over glucose. Pretty amazing. I just wonder how many other things we're going to discover that have, doctors say there's no treatment and all this. Persistent family members are going to track down that, hey, actually the brain works great on ketones. Well, that's epilepsy. There's a subgroup of childhood epilepsy that gets better overnight when you cut the carbs out, when you let the ketones go up and people run on fat. Let me end up with a few things. A clinical alert: if you're a medical person, a pharmacist, and you see someone on an SGLT2 inhibitor, which is all the rage, a drug that's come out for the treatment of diabetes that reduces heart events, but at the expense of a condition called ketoacidosis. And low-carb practitioners had never seen ketoacidosis in their nutritional ketosis type of practice until these medications start being used. Now, they're very effective. Doctors like them because when you let the urine pee out glucose, the blood glucose goes way down, and you're less of a bother to the doctor. So the problem is, it may be that we're the canary in a coal mine, meaning we teach people not to eat the carbs, so they're more likely to get ketoacidosis, although it happens in people who don't do low-carb diets. But so I take people who come to me off these immediately. There's even a risk in people who eat carbohydrates of ketoacidosis, and they don't know why, which is one of the worst things that can happen with a new drug. You don't know how to mitigate or prevent that life-threatening complication. So I'm sure you're still wondering about cholesterol levels, heart disease, all these things I'm sorry I couldn't get into in one brief hour. One of the best studies done, I pulled it up before, the SHI study, almost any diet can cause weight loss. You cut the calories, either you say it explicitly or not, you cut out junk foods. There are a lot of common elements of these other types of diets. But the metabolic effect is different. And LCHF reduces the cardiometabolic risk by targeting the metabolic syndrome. The problem is not everyone's heard about the metabolic syndrome, or if they go to conferences on metabolic syndrome, they only hear about drug treatment for metabolic syndrome. So if you look here, the triglyceride HDL gets better on a low-fat diet, but it gets more better, so the reduction is greater on a low-carb diet, this being the sort of poor man's estimate of the small LDL. So if the triglyceride HDL ratio is under 1 or under 0.7, you're pretty much assured there's no small LDL in the blood as well. So the cardiologists are talking about, well, LDL, there's good LDL, bad LDL. Low-carb diets lower the green bar here, keto, the small LDL cholesterol. Well, we don't look at that. We look at ApoB, no problem. And so this is a great paper that Volek, who's at Ohio State, 2008, showing differences in diet types. And my style has been to not say that other things don't work. It's like a VW manufacturer saying a BMW or an American car doesn't work. I mean, you can say it works better or not, but all of these other things can work. And don't say that a low-carb, high-fat diet doesn't work, or I'll pull out that terrible gravity metaphor yet again, and you'll roll your eyes and, okay. So there is a U.S. organization. So you show me studies and all that, but I'm going to wait until there's an organization that backs this. Okay, we got it? The Obesity Medicine Association, the largest group of medical obesity treatment doctors in the world, because it's the only one, medical, not surgical. There are a lot of things we can do as a obesity medicine specialist. You can use lifestyle medications, although in Canada, sadly, you can't get some of the medicines that are used in the U.S., which makes it even more open for lifestyle change. Yay. You won't be distracted by the people coming in, I want this drug, that drug. You just say, let me do it with lifestyle. And in the obesity algorithm, which is basically the guideline from the Obesity Medicine Association, downloadable for free at the obesityalgorithm.org, the very low carb diet or keto diet is in the guideline of the Obesity Medicine Association. It's interesting to see the two new research conferences. Metabolic Therapeutics Conference started in Tampa, but it's going to be in LA. But it's basically the Dom D'Agostino and his group. Great conference, the largest one wrapped around metabolic therapeutics and nutritional ketosis. This year, Ohio State put on a meeting on nutritional ketosis. And then there are all these other meetings where people just want to get around and talk about keto or low carb. They tell their story. They share their enthusiasm. It's pretty interesting to see. So around the country, people get together, pay money, and wear funny T-shirts like Keto Fest and things. And I envision one day there will be a conference where there's an award for the best bacon costume. Like my child used to go to Comic-Con, and you dress up as Pikachu or something. Back to the more serious, although I should say this is serious. This is people's lives. And we had a event here, an ADAPT event in West Van. And, it's pretty amazing to have people come up and say, you've changed my life. I'm so grateful. And I just have to say, well, I thought that's what doctors did. What I've just gone through is not known. In fact, it's feared. And there are a lot of reasons why that is. But it's a great way to practice medicine, and especially internal medicine, obesity medicine. Take off my cheerleader hat for obesity medicine. So what research really needs to be done? What are we doing? Well, there's an ongoing study that's done in the VA system, which is our kind of HMO for veterans that Will Yancey's doing. That's going to be a randomized trial, kind of like the Hallberg paper study, but it will be truly randomized. And they're basically in finished data collection. They're in data analysis phase. We're going to be looking at the retrospective analysis of the people who've come through not only my lifestyle medicine clinic on keto, but also the Diet and Fitness Center. So if someone says to you, you have to lock me up to lose weight or fix my diabetes, you'll say, aha, I know where you can go. So people travel to Little Durham, North Carolina from all over, sometimes spending 6 months. The problem is it's about $2,500 per week to stay there, so it's not for everyone. Trouble with the access there. Multi-site RCTs of LCHF with clinical endpoints are sorely needed, and these are only studies that can be funded by either big organizations or big pharma. Of course, you're not going to count on them to study this unless they got the idea that my drug will look better if I use a better diet. I don't quite understand why at least the obesity medicine drug companies aren't thinking about that. Your drug will look better with a more powerful diet. And I want to be involved in an RCT or give all the information I know because our involvement with the Atkins book and with these two new companies, I realized that suddenly I'm going to be one of them. The people that I avoided for so long and didn't trust anyone who was in the company, but there has to be ways to get this information out, and that's why I'm more open to being involved in those. So back to the old way of treating diabetes. There's nothing new for diabetes, for obesity. And the main fear about cardiometabolic risk and heart disease, it just works in a different way. It treats the metabolic syndrome, not the total LDL, total cholesterol. So there's a time that has to pass for this information to get out. Blair O'Neill, a former cardiology association president here in Canada, has invited me to teach next month at the Canadian Cardiology Association. We're doing a workshop. We'll present most of this data and the practical aspects. I assume we'll get some, arrows thrown at us and all that. So, I think at the end of the day, as we talked about, doctors want their patients to get better. There's kind of an irrational fear about something old, or you can say it's new, and there's all the science behind it. And again, it's been my pleasure to see the group here grow and now be on the verge of collecting more and more data. It's been exciting to see one of the biggest groups in the world treating diabetes, diabetes.co.uk. You guys are here and using digital training, digital platforms. It's really exciting to see. And yet, if you just do one-on-one with a patient with a piece of paper like I do, it works pretty well too. Thank you so much.
Well, thank you, Eric. That was great. And I just want to say that a lot of the things that Eric touched on there, we've been talking about for the last few days, and the IPTN is working on and trying to do some of these things to contribute a little bit to some of the next steps. I think we've got some time for a few questions. I don't know if your microphones are working. If you click on the button, if not, I can run the microphone up to you. But
right. Thanks. That was a great talk, and you learned so much at these talks. But in terms of the practical aspect of this, in terms of recruiting people and getting them adapted, and then transitioning out of the program and continuing, so coming in, do you find it's best to ease people in by reducing carbohydrate or cold turkey, and then going out? What's your compliance like after? I assume they're like 12-week interventions. What's your compliance like 6 months or a year after?
And my clinical practice is the unintended cold turkey cessation of carbohydrates. And some people knowing that it's like an addiction, like you do cold turkey cessation for cigarette smoking. We cut all the carbs out, 20 grams on one day. There's one study that was done that took people gradually down, done over 10 years ago. Looked like similar results, but the approach that I use, because I'm in a referral practice, not everyone knows what method I'm going to use. I have to sometimes do the pitch to, why don't you try this? I cut the carbs all out at once. I don't know if it's better to do it gradually or not. That's one of those unstudied areas that would be great. How long people stay in and the percent of people who stay, I have estimated in a couple ways, using 100 consecutive sample, 100 in a row, and having a trainee track them down and see. So through the years, it's about a 50% retention rate at a year, which is about right for an obesity medicine practice. If someone gets ketoed or low carb and it catches fire and they've been doing this for 3 years, many of the patients I have need to lose 200 pounds, and they follow this. It's a lifestyle change. You never add back carbs. And so if someone's doing it for a very short term, what I'll explain is if you go back to what you were eating, you're just going to go back to where you were. It's just a matter of time. Most people will learn something like the minimal, okay, I don't drink sugar in my drinks. And if you're young, you're active, that might be all you need to do to sustain it. So the individualization of the maintenance, we say, depends on where people are, how severely affected they are. And some people never have to reincorporate carbs again. And that's new compared to 10 years ago. And you read the books, it'll say you do 20 grams or less for 2 weeks, and then you add back. And that doesn't work. Or what I'll say, it's the over-the-counter method. I mean, it'll work if you don't have a very serious issue. But if you're treating diabetes, obesity with a couple 100 pounds to lose, you got to stay 20 grams or below for the duration. Yeah, way at the top. Oh, I'm sorry. You have that. You go first. Yeah, sorry.
Thank you for that. When you're educating a patient on how to de-prescribe their own insulin, could you share with us what instructions you give that?
Sure. So the brass tacks of my clinic is people come to me as a consultant. I'll spend 30 minutes, 45 minutes, or 10 minutes if it's right before the class that I teach. Do it real fast and get it all done, and you learn shortcuts. I do labs at the baseline if they haven't had them, like an annual physical with a focus on thyroid. And I wait a week, have people come back to a class, and it's an hour-long class. I use handouts that we developed from the clinic with the essence on one page, a one-pager with all the state of that food. And at the end of the class, if someone's on diabetes medicine, I'll have them raise their hand. And if is anyone on insulin? Yeah, okay, you need to stay. And I check everyone out. If they have hypertension, I'll say don't add bouillon because you might raise the blood pressure, and they can go. And the people with diabetes, I look them in the eye and I say, are you going to do this? And they say, yeah. Okay, when are you going to do it? Tomorrow. Okay. Tell me your insulin. I write it out on a piece of paper. 100 units, short-acting, 200 units, long-acting. What's the lowest blood sugar in the last week? Because they're eating standard amount of carbs. It's not going to change much. What's the highest blood sugar in the last week? And if it's if it's close to normal, I'll say I need to reduce your insulin by 50%, one half. I'll write it out because some of my patients don't remember things so well. If you want someone to remember it, you write it down, and I'll write down the new regimen, and I'll say if the blood sugar is under 100 milligrams per deciliter or 6, or let's say 7 millimole, do not take insulin at that time. And I'll say what will happen if your blood sugar is 7 and you take insulin. Most people will say, well, my blood sugar will go down. It'll go too low. Right. Don't take it. Now, you're fighting sometimes 20 years of taking insulin. So even in the best hands of these kinds of recommendations, people might not do it. You may have to repeat it over and over and over. But the thing you want to be careful about not having is a low blood sugar event. You'd rather have the blood sugars be a little high. And I go back and forth with my endocrinologists down the hall who want to get the blood sugar down while people are losing weight, and then they gain weight because they increase the insulin to keep the blood sugar down, but the weight goes up, and then you don't ever fix the diabetes because you still have insulin resistance from the obesity. So there's a bit of an art to it. I do give out my cell phone. I've never really been called for what happens usually is there's this, I'm not going to call my doctor. Are you kidding? So if someone has a low blood sugar, they just take whatever they're taught to have, a little orange juice, a couple of glucotabs, a measured amount of glucose. Some people, get the whole Snickers bar and then they go up, but that's okay. So when someone comes back at a month, and I used to have people come back every week because I was so worried about it. And then the clerk said, Doc, you don't have any appointments in a week. Okay, let's try 2 weeks. It was against my better judgment because I was worried and I didn't know. Well, nothing bad happened when people came back after 2 weeks because when the blood sugar is low, they just don't take insulin. So my method is not to tell people a sliding scale, but let the blood glucose go up to a certain level, use a sliding or a short-acting if you need it, and intermittently stop using the insulin. So when someone comes back, the clerk told me you don't have any appointments at 2 weeks. Okay, let's do 3 weeks. Well, you're out of town in 3 weeks. Okay, so I started saying, change the insulin and have you come back in a month. It wasn't easy for me, but nothing bad's happened. So I understand the wanting to know and being worried at first, and that's okay. But as long as someone's checking the blood glucoses and you Always check the blood glucose before taking insulin. Always, 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 and not everyone's been taught that. I think you'll be in good stead. And then when someone comes back, let's say they went from 200 to 100 units of insulin, and now they're not taking it 3 or 4 times, and all the blood glucoses are almost normal. You cut back in half again, or a third. You'll get a feel for the trajectory of it. And at this point, I think it could be digitized and somehow, at least the minimal, really important thing is that don't take insulin if the blood glucose is under a certain level. And as you saw, some people are off in the first week. I mean, even if you made them come back in a week, they're already off the insulin. I've learned to be able to sleep and not worry about it. Even now when I say, see you back in a month, yeah, it's okay. Yes.
Thank you, Dr. Westman, for a really fascinating lecture. My wife is trying to get me on board on the ketogenic diet, but after today, I think I'm a believer. I do have 2 questions.
Do you believe in gravity?
With my eyes closed, yes.
Well, maybe you missed the first part of that. That's why I wondered. Okay.
Anyway, I do have 2 questions. The first one is, we were taught in med school, at least where I went to school, that glucose is the preferred fuel for the brain. That's my first question. Second question, does carbohydrate sensitivity factor in to a type of glycemic index? I think that was the study from University of Alabama, prescribing now that we can get rid of diabetes just by diet modification.
Yeah, so we're all taught that the brain required glucose. We were all taught that the muscle preferred, or brain preferred glucose. You have to understand that all of these studies done that say these things were done in people who eat carbohydrates. So if you're eating 200 or 300 grams of carbohydrates a day, your brain is going to mainly use carbohydrate. But when you make that shift, the brain can actually use ketones just fine. And under a low-carb circumstance, that is preferred or not. I mean, I was talking with a professor of internal medicine professor, but he was a cardiologist. He had petri dishes of heart muscle. I guess you could do this with brain tissue. I'd never seen it done, but you put the muscle in a petri dish and you add ketones, fatty acids, and glucose. The heart muscle itself prefers the fatty acids and the ketones. And the last thing it takes up is glucose. So that would be a better way to really know if it was the preferred fuel. I know that the brain can adapt to using ketones just fine. Carbohydrate intolerance, certainly the genetic contribution to how you respond to the carbohydrates is why people are frustrated that their spouse loses weight faster than they do, or that there are individual variations on this. Some populations develop diabetes at lower weights, but this will work regardless of that genetic background. But if you're using a diet with more carbohydrates, a low glycemic diet, and I define total carbohydrate per day as the metric for knowing how much your body has to process. If you're adding more carbs in it and you have carbohydrate intolerance, that diet might not work. And then if you do the genetics to, okay, well, it works for these people. Okay, well, but that's because you had more carbohydrates. There's a classic sub-study of one of Christopher Gardner's study where he looked at people with insulin resistance and insulin sensitivity. 2x2 table, the low-fat diet worked for those who had insulin sensitivity. So they were not carbohydrate intolerant. It did not work if someone had insulin resistance. The low-carb diet worked for both. So when I looked at that 2x2 table, I said, well, if you're going to choose one, use a low-carb diet. All the other people look and say, well, looks like low-fat works just fine for those who are carbohydrate sensitive. And that's part of the confusion of why certain diets work for some people and not for others. I see a lot of Weight Watchers rejects in my clinic, and the problem with some of these companies is they say that if it doesn't work, there must be some problem with you, or you're not doing it. You clearly not know people are doing it. It's just not matched for their metabolism. But because of the basic biology and physiology I went over, this will work for just about everyone.
Thanks for a great talk. In patients who are polypharmacy for diabetes, like oral hypoglycemics in addition to insulin, what's your strategy for deprescribing initially if they're fully committed to doing it from the start?
The oral agents are not very powerful, and yet they have a certain comfort that someone's taking something for diabetes. So this is the art of it, that if I take away insulin and the other injectables and the sulfonylureas and they're left with metformin, I'll keep them on metformin. But I know it's not going to be very potent if someone has been on insulin and all these other things. Usually you start with metformin. When that stops working and they're still eating carbohydrates, you add sulfonylureas. When that stops working and they're still eating carbohydrates and they're gaining weight, more insulin resistance, you add more injectables and things like that. I'll stop the other oral meds or other like the long-acting injectables right away and focus on the insulin management. Make it easy for me, easy for the patient. And there's a certain benefit for being taken off of medicine immediately. And then you see your blood glucose is even better. So I'll reinforce that at a return visit. So let me see, your blood glucoses are better and you're off of medicine. Wow, isn't that great? Yeah, that's fantastic. So those other things don't really matter, so you can just stop them.
Hi, Doctor. Thank you for your presentation. I just have a question. What are the risks of this type of diet, like in terms of constipation, colorectal cancer, or gut microbiota changes? Thanks.
So I think of risks and I think of side effects. So side effects most commonly seen are people going to the bathroom for a bowel movement less often. And that's not always constipation. So yeah, I take time to explain in the first class that how often you go for a bowel movement doesn't matter. And in my area, some people were taught by their mom that they had to go every day or something was wrong. So it doesn't matter how often you go. But if you have hard stools or hard to pass stools, that's constipation and that's not good. So I use the remedy of magnesium supplementation for people, although you could treat it by bouillon and extra salt supplementation, and making sure people are drinking plenty of fluids. And then if someone is having true constipation, hard stools, hard to pass stools, I'll make sure they're eating their leafy greens and veggies that they're supposed to eat. Sometimes they don't. If I recommend a maximum amount of vegetables, they go, oh, maximum means I don't need any. That's the maximum, right? So colorectal cancer, like the true risk, no evidence for that. You get the weak science being trumpeted as evidence, and it's not. That's an easy one. The other more side effects, muscle cramps, often seen in very low-calorie diet programs or even post-op bariatric surgery. So things that really work, you might get muscle cramps. Magnesium supplementation helps relieve that. Little clinical tip is a squirt of mustard or pickle juice will immediately take it away. Or you give milk of magnesia, a teaspoon at bedtime for a week, and it fixes the constipation and the muscle cramps. Don't worry about the colorectal thing. It's one of the best essays I've seen is written by Gord Guyat over at McMaster on how that is overblown bad science. Don't worry about colorectal cancer.
Thank you very much for your talk. I was hoping you could comment on renal disease. So how low do you go with GFR? Do you give any specific recommendations to your patients? And with the magnesium supplementation in renal disease, I'm always a bit nervous. So I was wondering if there was any art or kind of caveats to your management of patients with CKD.
So renal disease has a continuum. it's from diabetes and you have proteinuria or just a mild elevation of creatinine, that can actually get better because it's diabetes that's causing the kidney trouble, not the food. Oh, food causes the diabetes. You fix the diabetes from changing the food, the kidney function gets better. I probably have had about 10, not many people with advanced renal insufficiency, meaning a creatinine of 3, 4, 5. I mean, at that level, it doesn't really tell you the difference. Most of them do just fine, and I just measure the creatinine over time. But there's one paper, Facchetti et al. I can send it to you if you want, where they studied a keto diet with polyphenol. I didn't really know why, and actually there was a longer time to dialysis when they changed to that kind of diet. Now, it could be the file drawer bias that someone did a study and it worsened it, or they didn't find it and you don't have it published. But it suffices to say there is a study of it. But my clinical experience in it is pretty small. There's some anecdotal case studies you can pull out and at least show that somebody has followed someone with advanced kidney trouble. Now, if someone's on dialysis, that presents an interesting issue. It works just fine, but as the dry weight goes down, the person doing the dialysis, if it's hemodialysis, needs to know what the weight loss was, because they adjust the dry weight based on the total weight. And so I have communication with the hemodialysis folks. I actually give a printout of what the body composition is. As they're losing weight, they can adjust the dry weight down. And this goes back to the old thing that eating protein raises the GFR. Old teaching, and it doesn't mean that eating protein causes kidney trouble. And this isn't a high-protein diet, it's a high-fat diet. So and there are several places where this logic just doesn't hold true, that it would be even a concern for kidney trouble, but I know it's out there.
Thank you.
So I would just should I repeat the question? So I've been seeing a lot of obese patients with heart failure who are on large doses of Lasix. They also watch their fluid intake and sodium intake. And I just wanted to get some wisdom on how to practically advise people on how to track weight, whether are they just losing water weight, how to adjust their Lasix dose, etc.
Yeah. So the patients I have who have heart failure and the LVADs are closely followed by their heart failure team. But at the end of the day, the sum total of the sodium intake and losses is measured every day by the weight. So these patients do daily weights, and if there's a 5-pound increase in weight in one day, they call. So they actually call the heart failure center, not me, because the Lasix, you have to have clinical practice. You double it, and then you take it in half, and if you've been on it a while, it doesn't have an immediate effect, and so that's a complicated sort of deal. But the sodium sum total balance sheet will be the weight is what you're monitoring. Occasionally, so some people will have some foods that are keto, like corned beef, very salty, and they don't pay attention, and their weight goes up, and some people will have pork rinds that have a lot of salt or something else. And but the other phenomenon, now not talking about heart failure only, when insulin goes down, your body gets rid of sodium better. So some people will have a diuresis at first, sometimes 5 to 10 pounds the first few days. Okay, but then that's a cause of frustration the second visit, because I didn't lose the 5 to 10 pounds like I did first, but that's okay. It was water weight. You're still losing the pound or two of fat mass per week. But so I don't worry so much. While the salt, most of my patients are on a 2-gram per day restriction, and nobody does it. I mean, so there's another just kind of, when you start really taking over, if you really want people to follow it, you may have to pay more attention. Or the other thing that I worry about in these patients is the vitamin K, and the anticoagulant has to be monitored very carefully. And now they're home machines that these patients are checking their their blood thinner every day. If the blood thickens in someone with a prosthetic valve or with an LVAD, basically the blood clots and they die or they have a stroke. So that's very carefully monitored. But the INR can be checked at home, the weight can be checked at home, and most of my patients are already trained in doing that. Makes it easy for me.
All right, well, thanks again, Eric, and please join me in thanking Eric for his talk today, and thank everyone for coming.